Sangini Kumar, fellow from Vedanta Hospital, and moderated by Dr. Deepak Sareen and Dr. Karan Gupta. So, over to Dr. Sangini.
Thank you, sir. Good morning. I'm Dr. Sangini. I'll be presenting the surgical anatomy of the parotid gland and the pathological classification of salivary gland tumors. So my talk will be divided in two halves. The initial half will be focused on the surgical anatomy, and the latter half will be regarding the pathological classification of tumors and the peculiarities. So I would like to begin with the surgical anatomy. The parotid gland is the largest salivary gland. It is mainly serous and has a few mucinous acini. Each gland weighs around 25 grams, is irregularly lobulated, wedge-shaped on coronal section, and often resembles a three-sided pyramid. Now, there are some specificities when it comes to the embryological development of the gland. There are some unique features to the parotid gland. The first is that it is the first gland which starts to form out of all the three major salivary glands. Then this process usually begins in the 6th to 8th gestational week. It develops as outpouchings of oral ectoderm into the surrounding mesenchyme. Now, what is important is that the growth of this gland is the direction of the growth of the gland is such that it ends up surrounding the entire facial nerve. So the gland grows in a posterior direction as the facial nerve advances anteriorly, and this is how the gland ends up surrounding the facial nerve. Now, another peculiarity is that the parotid gland is the last to become encapsulated, as a result of which there is entrapment of lymphatics deep to the capsule of the parenchyma of the gland, and this is why parotid is the only gland with intra-parenchymal lymph nodes. Now, coming to the anatomical extent of the gland, superiorly it is bounded by the zygomatic arch. Inferiorly, it lies at the upper part of the neck. It overlies the posterior belly of digastric and the anterior border of the sternocleidomastoid. Anteriorly, it extends. Anteriorly, it overlies the masseteric muscle, and posteriorly, it lies below the external auditory canal onto the mastoid process. It overlies the lateral process of C1. Medially, it fills the gap between the mandible, mastoid, and the styloid process. This is where the facial nerve also emerges. And laterally, the extent is till the lateral wall of oropharynx. Another interesting thing to note is the accessory parotid gland. It is nothing but an anterior forward extension of the gland. It is often detached from the main gland and lies between the zygomatic arch and the parotid duct. Now, coming to the external features of the gland can be described in four surfaces which are separated.
Sangini, we can't hear you.
Sir, I think we lost the connection. Sangini, sorry to interrupt. Dr. Sangini, am I audible?
Describing the external features in detail. So the gland can be described as four surfaces and which are separated by three borders. The four surfaces are the superior or the base of the pyramid, the superficial, the anteromedial and the posteromedial. The three borders which separate the surfaces are the anterior border, the posterior border and the medial border. The apex of the gland is directed downwards. It overlaps the posterior belly of digastric And the importance is that the cervical branch of facial nerve and divisions of the retromandibular vein, they emerge through this. Now describing each surface in detail, the superficial or the lateral surface, it's a concave surface, it is the largest surface, and the layers from outside to inside are the skin, the superficial fascia, which contains the anterior branches of the greater auricular nerve, the superficial parotid lymph nodes, and SMAS. I'll be describing SMAS in detail in my upcoming slides. Then third is the parotid fascia, which is thick and adherent to the gland. And finally, fourth, the parenchyma of the gland and the deep parotid lymph nodes, which are embedded in the gland. Now, what is important here is the branches of the greater auricular nerve. Now, the greater auricular nerve, it lies superficial to the gland, and it often divides into two, the posterior and the anterior branch. And usually during the time of parotidectomy, it is often possible to preserve the posterior branch. The anterior branch may have to be sacrificed, and this results in paresthesias of the ear lobule and the cheek area in the postoperative period. Second is the superior surface at the base. Now this is closely related to the cartilaginous part of the external auditory canal, the posterior surface of the temporomandibular joint, the superficial temporal vessels, and the auricular temporal nerve. The anteromedial surface is grooved by the masseter, the lateral surface of the temporomandibular joint, the medial pterygoid, the emerging branches of the facial nerve, as well as the parotid duct, which emerge from this surface. Now the posteromedial surface. The posteromedial surface, it lies on the mastoid and the styloid process and the structures which are closely related to them. The structures which are closely related to the mastoid process are the sternocleidomastoid muscle and the posterior belly of digastric. The structures which are closely related to the styloid process are the muscles, which is the styloglossus, stylohyoid, and stylopharyngeus, which is attached to it. Now the carotid sheath is in close contact, and the external carotid artery, it enters the gland through this surface, and the rest of the vessels in the carotid sheath, the internal carotid artery and the IJV, they get separated by the styloid process from the external carotid artery. Another important aspect of the posteromedial surface is the fact that the facial trunk, it enters the gland through this surface in between the mastoid and the styloid process. Now briefly describing the borders of the gland, the anterior border, which separates the superficial surface from the anteromedial surface. The structures which emerge from this are the parotid duct, the terminal branches of facial nerve, and the transverse facial vessels. The posterior border, it separates the superficial from the posteromedial surface. It overlaps the sternocleidomastoid muscle. The medial border separates the anteromedial surface from the posteromedial surface and is related to the lateral wall of the pharynx. Now coming to the superficial muscular aponeurotic system, SMAS, which lies in the parotid region, and its clinical significance in day-to-day practice. Now SMAS is basically muscles of facial expression, which are superficial muscles of facial expression, which lie within the layers of the fascia. It was first described by Mitz and Peroni in 1976 on the basis of cadaveric dissections. Now, in the parotid area, it is located between the parotid fascia and the skin. It is attached to the parotid fascia for 1 to 2 centimeters in the pretragal region and becomes separate from the fascia in the cheek region, and it is clearly distinguished from the parotid fascia. The nerves which are in relation to SMAS, the sensory nerves, which are basically branches of the anterior cervical plexus, they are located between the dermis and SMAS. Cranial nerve 7, that is the facial nerve. The branches of facial nerve are usually deep to the parotid gland, and they're protected by the gland and the fascia. The muscles which are included in SMAS are the risorius, the frontalis, the platysma, and the peripheral portion of the orbicularis oculi. Vessels which supply are the facial artery and vein. The main arteries are located deep to SMAS, but perforating branches, they pass through the SMAS, and the subdermal vascular network is located superficial to the SMAS. So what is the clinical relevance of this? The flap that we raise in parotidectomy is usually subsmass, and this is for two reasons. One is to prevent injury to the branches of the facial nerve in areas where the fascia is deeply adherent to the SMAS, where dissection is difficult, and secondly, to prevent Frey syndrome. This is the reason why we raise the flap in subsmass. Now, second is the capsule of the parotid gland. The capsule of the parotid gland is formed by the deep cervical fascia, which splits to surround the gland. This is known as the parotid fascia. It continues anteriorly with the fascia of the masseter and is known as the paritodomasseteric fascia. It extends till the zygomatic arch. The deep part, it extends till the skull base and is thickened between the styloid process and angle of mandible to form the stylomandibular ligament. The fascia is tough and elastic, therefore any swelling in the parotid region is very painful because it is an inelastic fascia. It cannot be stretched beyond a point, and that's why these swellings are very painful. Now, another important aspect of the parotid fascia is that the relatively thin part of the fascia over the apex of the gland, it can lead to spread of sepsis into the parapharyngeal space from the parotid space. Another important aspect is that deep lobe tumors of the parotid, which are limited by the stylomandibular ligament, usually if they arise from adjacent to the stylomandibular ligament, they can expand both in the parotid space as well as in the parapharyngeal space, and they often present as a dumbbell-shaped mass. Coming to the parotid duct, the parotid duct of Stenson, it originates within the gland. It is enveloped by the deep lobe of the parotid. Small ductules connect the superficial lobe with the gland. It emerges from the anterior border of the parotid and travels across the masseter. It runs obliquely between the buccinator and the oral mucosa before entering the oral cavity at the parotid papilla, which lies opposite the second upper molar. Now, the duct is 5 cm in length and has an internal caliber of around 0.6 mm. Its relation to the facial nerve is that the facial nerve and its branches are always observed lateral to the parotid duct. Now, coming to the intraparotid structures, or the structures that lie within the parotid gland, from medial to lateral, these are the artery, the vein, and the nerve. So the arteries which lie in between the gland are the main is the external carotid artery, which enters the gland through the posterior medial surface, as I've already explained. It divides into the maxillary and superficial temporal artery within the gland. The maxillary artery leaves the enteromedial surface. The superficial temporal artery, it continues superiorly and exits the gland from the superior surface. The posterior auricular artery, it may also arise in the gland, and the auricular temporal branch of the mandibular nerve, it lies deep to the superficial temporal vessels. Now, the veins which are inside the parotid gland, this is the retromandibular vein, which is formed by the union of the superficial temporal and the maxillary veins. Now, the retromandibular vein is an important landmark. It is an important radiological landmark and otherwise has its own importance. It emerges from the lower pole and the vein is a useful radiological landmark for identifying the nerve. Now, coming next is the facial nerve. The facial nerve, it emerges from the stylomastoid foramen. just deep to the junction of the cartilaginous and bony part of the external auditory canal, usually as a single trunk, but a double trunk may also occur in few cases, in 3 to 26% cases, and it is usually associated with other anomalies of the external ear or the pinna. The main trunk, it lies approximately 1 centimeter from the posterior belly of digastric. It passes downwards and forwards over the styloid process and attached muscles before entering the substance of the gland. And this part gives off the posterior auricular branch. It enters the gland through the posterior medial surface. Once the facial nerve enters the gland, it divides into two main divisions. The upper is the zygomaticotemporal and the lower is the cervicofacial. The zygomaticotemporal or the temporofacial, it further divides into temporal and zygomatic branches. The cervicofacial further goes on to divide in the buccal, marginal mandibular and the cervical branches. These peripheral branches, they run forward. These branches, they run forward anteriorly, further divide into terminal branches. The branches leave the gland from the anteromedial surface. The terminal branches, as they supply the muscles of facial expression, and this pattern is known as the pes anserinus. Now, Patey's facio-venous plane, the facial nerve, there is no anatomical distinction between the superficial and the deep plane, but the facial nerve, it runs between the superficial and the deep plane, thus creating a differentiation between the two. So the gland is composed of a large superficial and a small deep part, and the two are connected by the isthmus, and the facial nerve actually is in close contact with this isthmus, and it basically sort of creates a differentiation between the superficial and the deep lobe. So the branching pattern of the facial nerve, as I've already told, has been described by various authors on the basis of both surgical as well as cadaveric dissections. The most commonly used classification is that by Katz and Catalano, which describes the 5 patterns. Another is by McCorman et al. And Davis et al., which describes 6 patterns. Then there is Kwok et al., which describes facial on the origin of the buccal, basis on the origin of the buccal branches. So I'll be describing the most commonly used classification, that's the Katz and Catalano classification. So type 1 facial nerve, it shows straight branching of the facial nerve. 1A is noted in 18% patients, and 1B is noted in 6% patients. There is basically splitting and subsequent reunion of the zygomatic and the mandibular branches. Type 2 is also known as the zygomatic loop. It is noticed in 14% of the patients, and subdivisions of the buccal branch, they fuse with the zygomatic branch peripherally. Type 3 is known as the buccal loop. Now 3 has further subdivided into 3 subclassifications: 3A, 3B and 3C. Now 3A is noted in 25% of the patients, 3B in 13%, and 3C is noted in 6% of the patients. Now major communications occur between the buccal branches and other branches of the facial nerve. Type 3 is the most commonly encountered facial nerve branching pattern. Type 4 is multiple loops. 4A is noticed in 10%, 4B is noted in 4%, and there is complex branching and anastomotic patterns between the major divisions. Type 5 is noticed, it is rare, it is noticed in 3% of the patients. So what really happens is that each patient, instead of one main trunk, there are 2 main trunks here. One is major and one is minor. The minor trunk, it enters the zygomaticotemporal division, and the buccal division, it originates from this division. Now, what is the clinical significance of knowing these branching patterns? The clinical significance is that cross innervation between the branches and divisions of facial nerve is most pronounced, like I've already said, between the zygomatic and buccal branches, and least for marginal mandibular nerve. So this explains why significant defects in mid-facial movement are rarely seen following injury to the buccal or zygomatic branches and are relatively common following a marginal mandibular injury. Now coming to the landmarks for identification of facial nerve. So facial nerve dissection can be done in an anterograde manner and it can be done in a retrograde manner. So first I'll be describing the landmarks for the anterograde dissection, where we first identify the main trunk and then go on, and then trace it anteriorly to identify the peripheral branches. So the most commonly used landmark at the time of surgery is the posterior belly of digastric. Now, it is the anterior border of the muscle, posterior belly of digastric, that is used to identify the nerve. The facial nerve, it emerges 1 centimeter above the superior border of the muscle near the insertion at the mastoid tip. Now, what is the advantage? It is easy to, although it's a soft tissue landmark, but it is easy to identify. The disadvantage is that in large tumors or malignancies, it can become adherent to the tumor or to the surrounding structures, and localization may not be easy in such a case. The second is a tympanomastoid suture. It lies at the junction between the tympanic part of the temporal bone and the mastoid. This is the most consistent landmark. It is easy to find, it is easily palpable at the time of surgery, and the relation to the facial nerve is constant, as this landmark usually leads to the stylomastoid foramen. It allows the nerve to be identified close to the foramen, where it is least subject to displacement. The facial nerve trunk, it lies 3 millimeters deep to its edge. Now, the disadvantage of this landmark is that direct visualization of the landmark can't be done at the time of surgery. So, it is usually a palpatory finding, but bony landmarks are more consistent than soft tissue landmarks. Next is the tragal pointer. It is a triangular process of the tragal cartilage. And the landmark is usually points to the emergence of the facial nerve. The facial nerve lies about 7.5 with a plus minus 2.5 mm distance anteriorly. The facial nerve is at this distance anteriorly and deep to the tragal pointer. The disadvantage of using the tragal pointer is that it is a cartilaginous structure. It is mobile. It is asymmetric, blunt, has an irregular tip, and may be displaced by large malignancies or large lumps of the parotid. Next is the styloid process. Though it's a bony prominence, it is less safe and less reliable surgical landmark because it is too deep. So by the time we have encountered the styloid process, most likely the nerve would have been injured. The advantage may be to some that it is easy to palpate. The disadvantage is, as a landmark, that it may be absent or poorly developed in 50% cases. Relation to the facial nerve, the styloid process in the facial nerve is 9.8 mm from the nerve trunk. Now, coming to retrograde dissection. Retrograde dissection means that we first identify the peripheral branches of the facial nerve and then trace it back to the main trunk. So this type of dissection is useful in revision parotidectomies, where we have a large or a soft neoplasm, where locating the main trunk would be difficult. So the branches that we can trace up to the main trunk are the marginal mandibular branch, the buccal branch, less preferably the zygomatic or the frontal and the temporal branches. So the marginal mandibular branch is traced at the angle of the mandible. The landmarks are the angle of the mandible. It is 1.5 centimeter below the lower edge of the mandible and lies superficial to the facial vessels near the submandibular gland. The buccal branch is located at the level of the midface and runs along the lower face of the masseter in close relation to the parotid duct. The zygomatic frontal or the temporal branches, they're less preferred. They cross the zygomatic arch anteriorly to and within 1 to 2 centimeters of the superficial temporal artery. They are vulnerable as they run superficial in mass and therefore can be injured easily. Now, the nerve supply of the parotid gland. The gland receives parasympathetic supply, which is secretomotor via the auriculotemporal nerve. The sympathetic supply, which is vasoconstrictor, is carried by the plexus on the external carotid artery and the middle meningeal artery from the superficial cervical ganglion. The sensory supply is basically from the auriculotemporal nerve, and the fascia receives the sensory innervation from the greater auricular nerve. So this is the reason there is paresthesias if the anterior branch gets, which is usually sacrificed. The blood supply main is by the external carotid artery. Venous drainage is the retromandibular vein. The lymphatic drainage is via the parotid nodes, which are superficial and deep both, which go on to drain into the upper deep cervical nodes. Now, coming to the microscopic anatomy of the salivary gland, this is important when we talk about the various tumors that arise from the parotid gland, from the salivary glands. So the salivary glands, the functional unit is a secretory acini and the ducts. The acini can be serous, mucinous, or mixed, like there is a mixture of serous and mucinous acini. The acinar ducts, they coalesce to form the intercalated ducts, which subsequently unite to form the main excretory duct of the gland. So the intercalated ducts, they go on to form the striated ducts, and these striated ducts finally unite to form the main excretory duct of the gland. The intercalated ducts are usually surrounded by the myoepithelial cells. The striated ducts, they enable active transport of substances out of the duct. The excretory ducts, they are lined with tall columnar cells, and within the major salivary glands, the acini are arranged into lobules and lobes within the gland. Now, coming to the second half, the pathological classification of salivary gland neoplasms. So the broad classification of salivary gland neoplasms is the benign epithelial salivary gland tumors, the malignant epithelial salivary gland tumors. Then there are certain hematolymphoid malignancies which may be associated with salivary glands, and secondary tumors that have metastasized to the salivary glands. So I'll be talking about the benign and malignant epithelial salivary gland tumors commonly encountered. So there are certain risk factors which are associated for salivary gland neoplasms. One is radiation exposure. So low dose ionizing radiations, they can increase the incidence of both benign and as well as malignant tumors. So Wadins and pleomorphic adenoma and mucoepidermoid carcinoma. Then smoking. So there's an increased risk of Wadden's tumor is seen in smokers, and Wadden's is specifically seen in smokers. Then Epstein-Barr virus infection, it is implicated in the genesis of bilateral Wadden's and undifferentiated parotid carcinoma. Others are CMV infection, which may be linked to mucoepidermoid carcinoma. Now, coming to the theories of formation of salivary gland neoplasms. One is the multicellular theory, which favors the transformation of the entire ductoacini unit and dedifferentiated cells to become dedifferentiated. Next is the reserved cell theory, which states that both the normal salivary gland unit and different tumor types are as a result of differentiation from precursor stem cells. Now, these stem cells are basically epithelial basal ductal cells which lie on the basement membrane at the abluminal side of the ductal system. Tumors which originate from the intercalated duct reserve cells are the adenocarcinoma not otherwise specified, the ethnic cell carcinoma, the adenoid cystic carcinoma, and the mixed malignant tumors and oncocytic tumors. Those originated from the excretory duct stem cells are the mucoepidermoid carcinoma, SCC, and salivary duct carcinoma. So, coming to the classification given by WHO, it has evolved in the recent years, and the most latest classification came out in 2022. For benign epithelial tumors, this is the list which comes under benign epithelial salivary gland tumors. I'll be describing pleomorphic adenoma and Warden's tumor, which are most commonly encountered. So, pleomorphic salivary adenoma, it's a benign mixed tumor. It is the most common tumor affecting the salivary glands. 60%, 65% it is seen in parotid, and 40% in intraoral minor salivary glands. The macroscopic appearance is that it is well demarcated, round or ovoid with broad base surface bosulations. Cystic change or calcifications may be present. It is variably encapsulated, and wherever capsule is present, it may be thick and fibrotic or attenuated and incomplete. On the cut surface, it has pericapsular nodules which may be seen. These are attached to the main body by slender pedicles. Now, what is important is that a simple enucleation of the body of a pleomorphic adenoma will risk detaching these nodules, which can be a nidus of recurrence. So it is very important to ensure that we have to ensure that there is no tumor spillage. This will prevent recurrences in future. Now, coming to the microscopic appearance, the basic component are the ductal elements and the myoepithelial cells, which are embedded in a chondromyxoid matrix. Metaplastic changes may occur, as well as degenerative changes which may occur. This heterogeneity which occurs due to metaplastic and degenerative changes, this can make diagnosis difficult. So the risk of malignant transformation, there is a high risk of malignant change, around 6%. Now, factors which are associated with malignant transformation, they include older patient age, male patients, long duration of tumor, multiple recurrences, and deep location of the tumor. Next, coming to Warden's, it is also known as adenolymphoma, papillary cyst adenoma lymphomatosa. It is the second most common tumor of salivary glands. It is exclusive to the parotid glands, and paraparotid lymph nodes may also be involved. It can be multicentric and or bilateral in 4 to 10% cases. Most commonly occurs in Caucasians and Asians, and lower incidence is noted in African Americans and Black Africans. Commonly seen in the 6th decade for females and 7th decade for males. Most commonly, it is seen in males who are smokers. Macroscopically, it is a well circumscribed tumor, thinly encapsulated soft mass with multiple cystic and solid or papillary areas, white or brown in color. It may be there may be coagulated tan exudate in the cystic spaces. Then microscopic appearance, there is oncocytic epithelium, which is characteristic. It is supported by a reactive lymphoid stroma. The cystic areas, they may contain amorphous debris. The tumor can undergo infarction or degeneration, and metaplastic changes can occur spontaneously or post an FNAB, the fine needle aspiration biopsy or a core biopsy. Then malignant transformation into carcinomatous or lymphomatous is rare with Warden's. Now I would like to describe the Milan reporting system for salivary gland pathologies. It is cytopathologies. It is basically similar to Bethesda, where we have 6 categories. and the FNACs acquired from the salivary gland pathologies. It basically tells us the risk of malignancy and what the probable management could be. So, diagnostic category one. So the diagnostic categories, there's six, like I've already told. First is non-diagnostic. In such a case, we have to repeat the FNAC. The risk of malignancy is around 25%. Then second is non-neoplastic. It is the risk of malignancy is around 10%. ATP of undetermined significance, it's 10 to 35% risk of malignancy. And fourth is neoplasm, which may be benign, or salivary gland neoplasm of uncertain malignant potential. If it's benign, it's less than 5% risk of malignancy. If it's salivary gland neoplasm of uncertain malignant potential, then it is around 35% risk of malignancy. Then suspicious of malignancy is 60%. And in case of frank malignancy, the obviously risk of malignancy is around 90%. Now coming to the malignant salivary gland tumors, they are uncommon entities and constitute 5% of all head and neck cancers. Again, classification given by WHO, latest is 2022, and this is the list of tumors which are included in which come under the malignant epithelial salivary gland tumors. I'll be describing the most commonly encountered tumors. So first is the mucoepidermoid carcinoma. It most commonly affects the parotid gland and it can also occur in minor salivary glands. It is usually a triphasic tumor which has goblet cell mucocytes, epidermoid cell, and nondescript cells of intermediate size and shape. On epidemiology, it is the most common salivary gland neoplasm. It is most commonly seen in females, can present anytime, but peaks in the 5th decade. The risk factors are previous radiation exposure. Macroscopic appearance, it may be circumscribed or infiltrated. Tumors are predominantly solid or tan to pink-white masses, often cystic, filled with viscous brown fluid. Areas of scarring may be present. On microscopy, the proportion of mucinous epidermoid and intermediate cells may vary. So low-grade tumors, they have plentiful of mucocytes, few epidermoid cells, and infrequent intermediate cells. Then mucin pools may be seen, and there may be a sclerosing or a fibrosing component, and reactive tumor-associated lymphoproliferation is characteristic for mucoepidermoid carcinoma. High-grade tumors are more solid. They contain fewer mucinous elements and with a preponderance of atypical epidermoid cells. High-grade tumors, they can be mistaken for squamous cell carcinoma, and histochemistry may be diagnostic here. So for mucoepidermoid carcinoma, there are some grading systems which are there. So there are 4 grading systems which are used: the Brandwin-Gansler grading system, the modified Haley, the AFIP grading system, and the MSKCC grading system. The AFIP grading system is most commonly cited. The parameters in AFIP grading system include the intracystic component less than 20%, neural invasion, necrosis, mitosis, and anaplasia, on the basis of which it's graded into low, intermediate, and high. Now, why do we need to know this? We need to know this because the prognosis depends on whether it's a low, intermediate, or a high tumor. The overall survival is 90% with low, 70% with intermediate, and 25% with high-grade tumors. Now, low-grade subgroup, they can be managed with surgery alone. Intermediate and high may require adjuvant radiotherapy because because we can get positive surgical margins and tissue invasion may be present. Now coming to acinic cell carcinoma, it comprises 7 to 17% of all malignant salivary tumors. 80% they arise in the parotid gland and 20% from the minor salivary glands or submandibular glands, and only 1% in the sublingual glands. Usually seen in males in the third decade of life. It most commonly presents as a painless parotid mass and arises from the acinic cells. Now, on macroscopy, it is a tan gray or to yellow or pink mass, rounded, well circumscribed, can be encapsulated. Areas of hemorrhage or cystic change may be present. Recurrent tumors, they are less well demarcated and they may be multinodular. On microscopy, it resembles the serous acinar cell of the normal salivary gland. Various patterns may be present which can coexist in a single tumor. These may be solid, microcystic, papillary cystic, and follicular. Histochemical staining is important for this because it can demonstrate zymogen granules. Now, reactive lymphoid tissue is again characteristic of acinic cell carcinoma and may mimic lymph node involvement. It is overall generally considered a low-grade tumor, has good survival rate. A high-grade aggressive subgroup may be present, that is the papillary cystic variety, which has poor prognosis. So for acinic cell carcinoma, long-term follow-up is mandatory and post-operative radiotherapy is usually required except for low-grade cancers. Next, coming to adenoid cystic carcinoma, it comprises of 10 to 12% of all malignancies of the salivary gland. Then it is the most common malignant tumor of the submandibular gland. In around 30 to 50% cases, it can occur in minor salivary gland and 5% in parotid gland. So less commonly seen in parotid gland, does not have a sex predilection, usually seen in 40 to 60 years of age and rarely occurs in younger age group. On macroscopy, the tumor is usually poorly circumscribed solid white tumor. It infiltrates into the surrounding soft tissue, muscles, and bone, and may also involve the lymph node by capsular involvement. On microscopy, there are the patterns that are commonly seen is the tubular pattern, the cribriform pattern, and the solid type. So the tubular pattern represents the most differentiated form of adenoid cystic. Then the cribriform